All right, today we are going to talk about children and adolescents. This is chapter 45 in the 5th edition. I am not sure that there is a specific chapter in the 4th edition that goes along with this. I think that in the revised edition they had a few chapters that are a little bit different. So the objectives are to recognize the need for interprofessional collaborative practice to meet the health and oral health needs of children and promote oral health literacy among primary care team members and caregivers, advocate for a healthy oral lifespan among children and adolescents, discuss fluoride consumption and therapy, including water fluoridation, fluoride toxicity, and then we want to compare and contrast the effectiveness of various types of professional topical fluoride gels. We want to employ the decay missing filled teeth and decayed missing filled surfaces indices to qualify clinical observations in children, quantify clinical observations in children and adolescents. And then finally detail various aspects of behavioral management of pediatric patients during dental hygiene care. So we know a fair amount about interprofessional collaboration at Pacific because of our different IPC and IPE programs. But interprofessional education is when students from two or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. Interprofessional collaboration or interprofessional collaborative practice occurs when multiple healthcare workers from different professional backgrounds work together with patients, families, and communities to deliver highest quality of care. So using an interprofessional approach increases the opportunity for children to seek preventative dental services. For instance, if children have some kind of oral exam or fluoride in their pediatric office, in their physician's office. Interprofessional education, or IPE, and interprofessional collaboration, IPC, are being integrated into practice as most educational institutions are preparing students for IPC, just like we do pretty well, I think, at Pacific. The oral health literacy of the caregiver impacts oral health outcomes and quality of life for the child. So the more that we can educate everybody about oral health, especially parents or caregivers, grandparents, then of course that improves children's outcomes. Oral health literacy, or OHL, is the degree to which individuals can obtain, process, and understand the basic health information and services that they need to make appropriate decisions. So oral health literacy, do they actually understand what they need and why they need it? And can they make a good decision about how to get best care or who to see to help them with that issue? So early childhood caries is the presence, I feel like I skipped no, I guess not. Early childhood caries is the presence of one or more decayed, missing, or filled tooth surface in a primary tooth in children younger than 71 months, which is roughly 6 years old. It's caused by prolonged and repeated exposure of the tooth to fermentable carbohydrates. And we want to strive for the appointment to be fun and stress-free with kids. So this is a hard age because everything kind of can seem sort of scary. And if their first dental experience is a bunch of shots in the mouth, noisy, drill, pain, then that really sets them up really bad for life. They're going to carry that fear with them. So we really want to see them young, before they have any dental disease, so that we can keep it a fun and stress-free appointment. And then these are just some images of early childhood caries with mild, just a little bit of decalcification, moderate, and then severe. So some more about early childhood caries. Dental caries or cavities remains a public health crisis for infants, children, and adolescents, impacting both primary and permanent teeth. The maxillary anterior teeth are the most susceptible for little ones, but other teeth may also be affected, but that's usually where the caries starts, is the maxillary anterior teeth. Exposure to dental caries at an early age yields short-term and long-term economic burdens for the parent and child. And then because you think about, losing primary teeth early, and then they have the space, and then how they're going to hold that space for when the permanent tooth comes. And if the space isn't held, then they're going to have malocclusion, and it's just a cascade of issues. The dental home is an inclusive approach of all aspects of oral health that result from the interaction of the patient, parents, dentists, dental professionals, and non-dental professionals. So infant oral care. So oral structures begin to develop in the 3rd and 4th weeks of embryonic development, so super young. Around 20 to 30 months, eruption of all the primary teeth has started to occur. And then during eruption of primary teeth, infants and toddlers can become very uncomfortable. There's a lot of crankiness, a lot of sore mouth, there can be fever. Healthy feeding and eating habits and oral habits really have to be practiced. We have to help encourage new parents, but also parents who have had lots of kids and just haven't learned about the proper oral hygiene for their little ones. So here's a picture of the overall eruption pattern. 6 to 12 months, they get their little baby mandibular incisors first, then maxillary, then the laterals, then the maxillary laterals, then they get the little baby molars, and then the canines, and then the second set of molars. The primary teeth include centrals, laterals, canines, first molars, second molars. This is known as the primary dentition. Over-the-counter topical gels, teething gels should be used with caution. This was kind of in the news not that long ago. The benzocaine-based teething gels should not be used in infants or children under 2 years of age. Some parents will slather that stuff on their little babies, and it can be very, very dangerous and unhealthy. So that's an important thing to share with new parents. So I'm not going to read through all of this because this is a lot, but this is the table from the 5th edition. It's table 45.1, and it just goes over the important aspects of caring for primary dentition. So using a smear, like not even a pea size really, it's like a smear of toothpaste. They have to be able to spit it out if it has fluoride. If they're not spitting, if they're still swallowing, then they can't use the fluoride-containing toothpaste. And but using a toothbrush with soft bristles the minute teeth start popping into the mouth. Prior to eruption, though, the parents can use just a soft washcloth or gauze to stimulate the gums and remove food. It's very important to talk to parents about no bottle in bed or in the crib, only water if they have to give them something, and definitely nothing else. No juice, no milk, no formula, nothing else. And we know that saliva is decreased at night when we're sleeping, so that of course increases caries risk. Encourage children to drink from a cup as soon as they can, or their first birthday, trying to wean them off of the baby bottle and off of even sippy cups. Instead of pacifying a baby with a bottle, rely on things like cuddling, patting, talking, singing. So we want to try and encourage parents to remove the bottle and whatever liquid they want to put in there, unless they're just doing water, And then if they have to take medication and it has some sweetener in it, then they be sure the parents understand the importance of cleaning their mouth after taking that medication. First dental appointment should be by a year, if not before, but at least by the 12-month mark. And then fluoride varnish can be used on very young children who have primary teeth coming in, especially if there's moderate to high caries risk. So bacterial and viral transmission to children, dental caries, we think about vertical transmission. The source of initial infection is through the mother. It occurs through the saliva. We call that a vertical transmission. Horizontal transmission occurs directly indirectly of exposure to saliva. Herpetic infections is another important topic to educate parents about. If they have, mom or dad has a herpetic lesion, to be very careful not to kiss baby and expose them to that virus. Symptoms of herpetic infection include fever, crying, oral pain, and an unwillingness to eat or drink. Gingiva can be very red and painful, blisters on the tongue and the lips. So children are most susceptible to the inoculation of Streptococcus mutans and Streptococcus subrinus between 19 and 33 months. So, roughly, what is that? A year and a half and 2.5. Caregivers should be aware of their dental caries and oral health status. So they should know, do they have a mouthful of decay? Because then they are just teeming with bacteria that they can end up giving to their little ones. So they need to know their own health status and obtain a dental visit at least twice a year, as we like to recommend, or whatever is recommended by their dentist or their hygienist. And then parents with herpetic lip sores can infect their babies by mouth kissing. So if a child is in daycare, if there's toys and rattles and sleeping mats, they should be wiped down, because if some other little kid has it, because they already got inoculated with that from their parents, it can spread on toys and stuff at daycares. So it should be all wiped down and clean at least twice a day with diluted bleach solution to prevent that transfer of the microorganisms. So here's another box table from the chapter 5. Recommended that caregivers seek preventive dental care at least every 6 months. We know that's pretty standard for us. Give babies a clean pacifier. Do not give them pacifiers that have been dipped in sugar, honey, syrup. This might sound like totally obvious to us, but it's important to explain that to parents, because they really don't necessarily think they might think it soothes the baby, keeps them happy, and puts them to sleep or something. They don't understand how it can be dangerous for their oral health. And then they might think that they've cleaned it by sucking on it and putting it in their own mouth and then giving it to the baby. They might think that has cleaned it off. And that, of course, is not a good theory either. So never clean a pacifier in another person's mouth. This practice can infect baby's mouth with bacteria. It's that vertical transmission. It should just be washed off with soap and water. Never share eating utensils with an infant. Another way to transmit bacteria. And then dental caries can develop as early as 11 months of age. If they have a tooth in the mouth, they can get a cavity. You don't have to hit a certain age, so it's important for parents to know that the minute those teeth pop in, they are susceptible to decay. So toddler to preschool, 2 to 6 years, oral health. So the oral health professional should provide literature at each visit that reflects the stages of development. In addition, oral health care professionals, along with primary care providers, must advise parents to schedule preventative oral care appointments for the child at least twice a year. And there's a couple good figures and boxes in the text that have some additional information. But by 2 years old, a dental home should be well established. Anticipatory guidance should include things like dietary habits, home care, growth and development. During ages 2 to 3, children are most susceptible to dental trauma from falling. The little things are not quite as coordinated yet, so they can fall and hit their face. Age-appropriate injury prevention counseling, so talking to parents about the things, everything's at their head level when they're 2 to 3 years old, running into stuff or tripping and things like that. Non-nutritive oral habits like thumb sucking, pacifiers, and bruxism should be discussed as well. Strategies to decrease incidence of early childhood caries. Using small amounts of fluoridated toothpaste inhibits decay and minimizes chance of developing fluorosis when used after age 2 to 3. Child needs to know how to spit, like we said earlier, proper brushing. Supervise the children when brushing. A lot of times parents can let them have autonomy and play with the toothbrush, but then mom and dad have to get in there and do a good job. Candies and gums should be given only to children who can manage them properly. So like xylitol candies or xylitol gum. So there's some things that are probably safer, like a lollipop or like some gels and sweet gels that you could give. The parents could give their kids if they wanted them to have xylitol, but they don't want them to choke on a piece of candy. Educate children on limiting highly refined carbohydrates. So talking to children and parents about that. Encourage children to discuss fears about oral health visits. So finding out what they think sounds scary and why it sounds scary to them, and then what it actually might be like instead of what they think it might be like. School age 6 to 12 years children and oral health. So there's a couple good figures. There's 45.6 and 45.7 in the text. So you should look those over if you can. The mandibular central incisors are the first primary teeth to exfoliate, and that's around 6 or 7 years old. Children and adolescents who receive sealants on non-cavitated pit and fissure occlusal surfaces have a reduced dental caries risk. So we know this, and we like to put sealants on to help reduce the risk of decay. The upper lip, maxilla, and maxillary incisors are the ones that are most often involved with injury. So 50% to 90% of injuries include either the upper lip, some part of the maxilla, or the maxillary incisors. So just reviewing this, as children enter primary school, primary teeth will begin to exfoliate, obtain preventive dental services at minimum twice a year, so the cleanings, but things like sealants, and then sports involvement. So the more active they get in sports, 31% of all orofacial injuries are related to sports. Ensure child has a properly fitting mouth guard. That's super important. Inquire about dental sealants once first permanent molars erupt around age 6 or 7. So adolescent stages and oral health, they're susceptible to potential high caries incidents at this age. Traumatic injury, sports injuries, they are susceptible to periodontal disease. It can happen at this young age. Poor nutritional habits, lots of candy and soda is probably what would be their ideal diet if they could. So that has to be talked to about parents and with the adolescent, because they're old enough to kind of talk about it at that point. Aesthetics and appearance is very important. So sometimes we can appeal to the ego and when we're trying to talk about healthy oral habits. Orthodontic and restorative care is a topic as well, especially talking about exposure to tobacco, like vaping is the big one. Younger kids don't really want to smoke traditional cigarettes as much anymore, but they definitely want to vape. And then drugs and alcohol, and social and psychological needs as well. Puberty and menses also can affect oral health. Hormonal effects in the mouth can be obvious during menstruation and during puberty. So that's another area that can really be affected. So let's see if I have some more. I don't think I have notes on that. But so adolescents have distinctive needs during the ages of 10 to 18. Dental hygiene preventive strategies during puberty and menses include stressing optimal oral hygiene via increased frequency and duration of toothbrushing with an extra soft toothbrush or a powered toothbrush, and meticulous interdental cleaning. Basically, sort of like with a woman who's pregnant, hormones sometimes just exacerbate the effects of the bacteria. So if they are having a kind of a puberty or a hormonal effect, just increasing their oral hygiene and being really, really meticulous can make all the difference. So that's important for us to talk to our young patients about. Therapeutic modalities include topical corticosteroids, frequent periodontal debridement, scaling and root planing, antimicrobial mouth rinses, fluoride rinses, gels, varnishes, and use of xylitol products. So a lot of things that we would use in the adult population as well. So talking about water fluoride, community water fluoridation has benefited the U.S. for approximately about 70 years. Public Health Service recommends optimal fluoride concentration at about 0.7. And then for drinking water, use of water fluoridation is very cost effective. It's a very cost effective mechanism that benefits all individuals regardless of their demographic background. Of course, some people don't like having something put in their water, but that's why we have some areas that don't have fluoride. But in general, it has helped to reduce the rate of decay. The fluoride mineral occurs naturally on Earth and is released from rocks into the soil, water, and air. And you can refer to figure 45.8 in the textbook for an image, but I think I might have put that here. So here's an image of varying levels of fluorosis. So normal teeth here, really no fluorosis there at all. Questionable just because I think of it's a little bit like whiter down here at the incisal edge. All around there might just be like a little bit more of a calcified appearance, I think is why they're saying it's questionable. But then on the very mild, you definitely start to see these kind of hypercalcified spots down at the incisal edge. Mild, even more obvious. Then we start to really get this striation and all through the tooth we get this kind of hypercalcified kind of look. And then we start to get kind of a mottled look with severe and the staining, which is definitely not what we want to see. So fluoride toxicity is very important though with any medication, which I kind of classify the adding of fluoride to water as like adding a medication. Honestly, that's kind of my personal opinion of it. And so it's really important for us to understand the toxicity and then to be able to share that with our patients. So it can occur if recommended doses for fluoride additives are not followed. While most U.S. communities have water fluoridation, there are still communities without water fluoridation system, which of course we know. Providers can recommend fluoride supplements. Dietary fluoride supplements in the United States are available only in prescription form, which is good. But you can also, if that is not if that is not the route that you feel strongly about, there's nothing wrong with not recommending that and then recommending other modalities and alternatives for preventing decay. Many people do use supplements and the parents are very careful with how they dose and children don't get fluorosis, but if they're not careful and they don't have a really clear understanding of it, I feel like it could do harm. So the supplements are kind of a little bit of a harder topic for me to talk about. I do think that fluoride in the water has benefited, but it's just important for people to know how much is too much. So children are highly susceptible to toxicity when the recommended dose is not properly followed. So, it's just super important for them to follow that recommendation. Chronic toxicity generally occurs after 10 or more years of exposure to high levels of fluoride, which is not associated with optimal drinking water. So if they have done supplements all through their youth and maybe they got way more than they needed, then they might end up seeing some fluorosis or some effects in their body. Dental hygienists are responsible for advising parents or caregivers about water fluoridation and fluoride supplements as follows. Determine if the water supply that serves the patient's home is fluoridated adequately. It seems to me that if there's fluoride in the water, it's probably adequate, I would imagine. But some, if they're in a non-fluoridated area, they may be more likely to actually want to consider a supplement. If there is an inadequate amount of resulting from filtration or lack of fluoride in the water, then discuss supplements options with the patients. Consult with a health or oral health provider regarding the need for fluoride supplements on and or home use fluoride gels if the fluoride history reveals a fluoride deficiency. So you can always instead of going the systemic route, you can always encourage more topical use as well, as long as they know not to swallow it. So there's different routes. Topical fluoride gels and varnishes. So in 2000s, fluoride varnish progressively replaced the acidulated phosphate fluoride gels and foams that we used to use, which thank goodness, because the varnish is so much nicer to use. APFs, or acidulated phosphate fluoride gels, with a fluoride concentration of 1.23%, or 12,300 parts per million, benefit children and adolescents in reducing incidence of dental caries in primary and permanent teeth. Fluoride varnish is used for caries prevention in clinical settings. So caution should be used when filling the fluoride tray with fluoride gel or foam. In addition, the manufacturer guidelines should be followed in addition to suction to reduce the risk of excessive ingestion. So if it's going to make them gag and then they're going to start to choke and then they swallow a whole bunch on accident, it can cause gastrointestinal irritation and nausea, which nobody wants that. So decayed, missing, filled teeth, DMFT, used for permanent dentition, expressed in total number of teeth that have decay or and are missing or filled in an individual. Decayed, the D includes carious tooth, filled tooth with recurrent decay, only the roots are left, defect filling with caries, temporary filling, filled tooth surface with other surface decayed. The decayed, the DMFT, is a well-established and documented indice used to measure dental caries in epidemiologic research. This index quantifies health status and clinical observations among primary and permanent dentition. So lowercase letters DMFT are used for primary dentition. Uppercase DMFT are used for permanent dentition. For M, missing teeth, only teeth missing due to decay or disease are counted. So not congenitally missing. Teeth that are unerupted, congenitally missing, missing supernumerary, or removed for other reasons other than dental caries are not counted. In addition, only teeth filled, that's the F, due to caries are counted. So restorations from trauma or hypoplasia, sealants, erosion, bridge or abutments, or root canals are not counted. So just fillings from decay. The individual score is a sum of the D plus the M plus the F, ranging from 0 to 28 or 32, depending on whether they have their third molars. The DMFT index in primary dentition is expressed as number of affected teeth. Individual scores for pediatric patients range from 0 to 20 because they only have 20 primary teeth. All similar principles to DMFT or the primary DMFT, except tooth surfaces, are accounted rather than individual teeth. For posterior teeth, 5 surfaces are used. For anterior teeth, 4 surfaces are measured. Individual scores range from 0 to 128 or 148, depending if they have their wisdom teeth. In addition to the DMFT, the DMFS, the decayed, missing, filled surfaces, has been used to quantify dental caries incidence among populations. Lowercase letters, just like the DMFT, are used for primary, uppercase for permanent. And when using the DMFS index for primary dentition, the score will range from 0 to 88 surfaces. That's for the primary. For posterior teeth, 5 surfaces are used, including the mesial, distal, buccal, lingual, and occlusal surface. And for anterior teeth, the 4 surfaces that are measured other than the occlusal surface, so buccal, lingual, mesial, distal. Note that in primary dentition, the decayed, filled teeth or surface has been used because of the inability to discern if a tooth is missing due to exfoliation or extraction due to dental caries. So, a little bit about behavioral management of the pediatric patient. During assessment phase, dental hygienists collect information about children's health and dental history. The AAPD guidelines recommends documentation in dental records of informed consent, instructions and information provided to parents, health history, vital signs, oral assessments, objective observations of pediatric patients, time-based record that includes name, route, site, time, dosage, and patient effect of administered drugs, and then adverse effects, if any. So the AAPD developed a guideline for healthcare providers and parents about influences on behavior of children as pediatric dental patients, with suggestions from behavioral techniques to use in contemporary dental practices. So during the assessment phase, the dental hygienist collects information about the child's health and their dental history and may ask questions about the child's temperament, their cognitive level, their fears, and their anxieties. So when you have all that information, it kind of helps you prepare for the appointment a little bit better. Once the treatment is planned, the dental hygienist must obtain consent from the parent and assent from the child. So assent from the child means they have to agree as well. The assent from the child is desirable prior to proceeding with each new procedure during implementation. I suppose if the parents say, no, this is happening, you'll do it without the consent, but the assent of the child gives them the feeling that they have some autonomy in what's happening, and especially if you go about it in a way that explains the procedure and kind of alleviates fear. Communication is the key, and the AAPD guidelines presents detailed information on several useful techniques. Pain assessment, recognition, and management during delivery of dental hygiene services is important because pain has a direct influence on behavior. So a complete review of the AAPD guidelines would be beneficial to any healthcare provider providing services to clients, including pediatric patients. And I will try and find that and post that in this week's section, the AAPD guidelines. Okay, that is it for this unit.